know, nothing tough here. Answers partially affect me every time, remember. Okay. So Muhammad, here we go. 59-year-old lady, asymptomatic, CT scan done for some menstrual problem. Creatinine was normal. This is Michael Marburger's case. And a CT scan showed this. Right-sided lower pole, 3 centimeter renal mass, enhancing. Left-sided 4.5 centimeter tumor, enhancing, somewhat heterogeneous. Bilateral renal tumors in a, how old is she? 59-year-old young healthy lady, asymptomatic, normal kidney function. What do you think? Yeah, yeah, metastatic workup negative.
I think to me, both masses can be involved as
Yeah.
also, at least the right side can be approached by ablative therapy if someone want to do it, and I think it's doable. Posterior, not close. At least from this cut is not close.
Medial though. Medial. You're just going to be close.
Yeah.
You could nail it.
True.
Potentially.
So yeah.
Yeah.
I mean, maybe a retrograde prior to this would be helpful, but I would say minimally invasive approach for both.
Okay. Any other thoughts from the panel? Seth?
No, I think there's two things. Whether you can do this in the same setting, whether you can do it or should do it, because you basically put both kidneys at risk, but I suspect that would be okay. And the other thing would be, would there be a role for tumor biopsy? And so bilateral, you think about hereditary forms of renal cell carcinoma, the central, if there's a central necrosis on the left, the right looks fairly homogeneous.
Mm-hmm.
I think at the end of the day, could probably proceed without it because, I suppose there's a possibility that you might have disparate histology from one side to the next. Are you going to biopsy both? I think you go, and if technically you've got the ability to do it in one setting, I do the left first. The left looks a little more complex. I want to make sure that I, was not in any hurry and could get that done safely, and if all that goes according to plan, have at least the in my hip pocket that I might go over and do the right. But I think staging it for those of us who may not have that level of experience would be also reasonable.
Okay, great. So, agree with everything we said, and she underwent an open left partial nephrectomy, pure oncocytoma. Pretty good, huh? All good. So then, what are we going to do on the right side, guys?
Well, usually oncocytoma rarely metastasize, but personally,
So
what I
let
would
me
do.
ask another question before we go there.
Yes.
So, anybody can answer, and this is just a discussion we're having. So let's say we had a biopsy of the left tumor, okay, 59-year-old lady,
Yes.
4.5 centimeter mass, little heterogeneous and all that stuff. We got a biopsy of that on the left side,
Yes.
okay, and it came back oncocytoma on the biopsy. 59-year-old lady. You can see the way this tumor is looking. What would we do? Still do it, right? It's not like you say, man, you're
Yes.
okay, no problem.
It's quite difficult to differentiate, especially the biopsy of cytoma.
Right. And the way this is looking, it could be something else somewhere else. So it would still get done. But anyways, so here we are now, Hassan. Left side done, pure oncocytoma. That's the more ominous looking tumor, so you got that. Now what do you want to do with the right?
The right side, if I have a pathologist and an interventional radiologist who will do a biopsy, I will do a biopsy. Otherwise, I will do a partial minimally invasive approach.
So pathology biopsy was indeterminate. On the right side.
Then I will, on the right side, then I will go and remove it. Because I think that is easily removable. I mean, you can make a point of observing it for sometimes 6 months to a year, and if it does not change you can continue observing it. The energy-based techniques are there, but I'm comfortable with minimally invasive excision. I will do it. I mean, to me, that is the first option.
Oh, I'm 59 years old, healthy lady, and I'm assuming that the left kidney function recovered okay.
Yeah, no
and
complications.
fine. You know, there's probably not, I mean, she's gonna need it. You can counsel her that it doesn't have to be done right away, but I don't think there's any harm in going if she's ready. You got a 3 centimeter tumor. So I think either way, I would counsel her on, we can watch, you're gonna ultimately need this out, or we can go whenever you're ready.
Perfect. She wanted a partial, so she got it. And right side was a clear cell RCC grade 2. So the smaller, more friendly looking mass, the point being, there is discordant histology in about 30% of patients with bilateral renal masses. So what's on one side does not necessarily mean it's the same on the other. We can talk about many other things here too, but let's just leave it at that this is one of the teaching point of this one. And so pure oncocytoma on the left side.
Dr. Gill, just a little point. I come from a school where I have been taught in neurology, do the easy one before the difficult one, and come from below, go up. So if it was me, probably I would start with what looks a similar partial on the right side, because the chances of saving the kidney is great here. And then I will do the right side, because there I might end up doing the radical. So what are the thoughts of you and the panel?
Interesting. I'm sorry. Yeah. Never do this to your host, and here I am, day one. So another way to think about it is to do the more complex one first, where you may be more likely to get some sort of acute kidney injury, and you've got a healthy contralateral kidney to help that kidney recover. I think what I take away from this is there's no one size fits all from a technical standpoint. And you kind of have to do what your experience says best, but I think the take-home message is both got to come out.
Both got to come out. And you know, Son, you were mentioning that let's just observe for a little while, and if it hasn't grown, then you know, blah blah blah. If it grows, then something else, etc., etc. And here is the publication that says growth rates of renal cell and oncocytoma under surveillance are similar. Okay, so I think in general the mindset that we're going to observe you, and if it grows, then we're going to do something. If it doesn't grow, we are fine. As if it didn't grow, then it means it's not cancer. That is just not true. And in patients who have small renal masses, who had zero net growth over a 12-month period, zero net growth. This was a publication from Bob Woodville's group. 79% of those were cancer, as long as they are enhancing, of course. Enhancing, small solid, small renal masses, zero net growth, who had a biopsy or for whatever reason required histology confirmation. 79% were RCC compared to 83% that actually grew in the 12-month observation period. So I, at least, rightly or wrongly, do not use growth in the 12-month period as a discriminant between increased risk versus not increased risk. Oncocytomas, RCCs grow at the same rate, and those that don't grow are as liable as potential, have the same potential for being cancer as those that don't grow. And I think more is the characteristic of the tumor, the enhancement, the Hounsfield units, etc., rather than growth rates.
For patients who you're going to put on surveillance, do you biopsy all of them? Some of them? What's your decision making?
Again, the size, small tumor, less than 2 centimeters. We know that tumors less than 2 centimeters, about 50% are, at least the biopsy is going to come back benign. In the large 2,000 patient series from Mayo Clinic. So if a smaller tumor in a elderly or a somewhat more higher risk patient, comorbidities, are folks we would say for active surveillance, more push them towards it, and those that are younger or tumors, instead of 4 centimeter, the cutoff really is 3. 3 is where the metastatic risk goes up significantly. At 4 it goes up even more compared to less than 3. All right, let's go on to the next case. Seth, 79-year-old gentleman, 79. So serum creatinine is 1.6. He has 2-drug hypertension. He had a left nephrectomy for some reason. We don't know. Prostate cancer, he had seeds. He had testicular cancer, he had radiation to the belly. And he had colon cancer, and then he had a hysterectomy and chemotherapy.
Are you sure this isn't a bladder cancer case? This is like my typical patient that I figured.
That's right. Yeah, 79. So, and so he shows up in my clinic, and he has this 5.5 centimeter tumor in the right solitary kidney. So once again, 1.6 is the creatinine, single kidney, 2-drug hypertension, and he's had all this stuff done to him. So, what do we want to do?
What side was the colectomy on?
Left side.
Left side. Okay, well at least that's good.
Yeah.
So this is a patient who has an imperative, if you're going to operate, has an imperative indication for nephron-sparing surgery. And I think that probably the most important thing, given also the appearance of his aorta, is to make sure he has a very thorough medical and cardiac evaluation to understand what his risk of surgery is, are there reversible factors, is his blood pressure under good control, and then make some independent assessment of his life expectancy, right? So if all of that sort of comes out positive, then I think this is a patient who you do a partial nephrectomy on, and you do what works best in your hands. If it's obviously, it'd be great to be able to do it lap robotic, but this would also be kind of a really easy, open, small incision. But if you got to do what you do best.
Agreed. So whichever will give the least complications.
I think this patient is a patient for me that requires a pre-treatment biopsy because you have 4 malignancies before. I just want to make sure before doing this surgery that I'm not dealing with metastatic.
And he's
disease.
79 and all that
Yeah.
stuff.
So
we can
I
somehow avoid
start
surgery
with the
would be the
biopsy
thing.
because I don't want to go for a partial nephrectomy if he doesn't have metastatic disease from other
Right.
one of the 2 previous urological.
Good point. So I told him, sir, you had prostate cancer, you have testicular cancer, you have colon cancer, you probably had kidney cancer already, and you made it to 79, you are indestructible. Okay, you're indestructible. And this little 5.5 centimeter guy is not going to do anything to you, so we can do nothing. And he said, no, I want something done. He absolutely was pushing for it. I said, fine. So, Seth, you hit it when you said that, look at the aorta, okay, some atherosclerosis going on right there. Creatinine 1.62, drug hypertension. So we said, he may have some renal artery stenosis. And we got an angiogram, CT angiogram, and that showed a gradient greater than 10% and was felt to be a functionally significant renal artery stenosis. You don't want to be putting a clamp on that and all that stuff. So this patient underwent renal artery stenting, and there is the stent being deployed, etc., etc. We sent him home for 3 months. He came back, and we did not do a biopsy. That was a very reasonable thing to do, but this was easily 10, 15 years ago. And so we did a laparoscopic partial nephrectomy. We made sure we clamped quite distally. If we were to come to me today, we would do it completely unclamped. It's a polar easy unclamped partial. But at that time, the ischemia time was 17 minutes and all that stuff. Negative margins. He peaked at 2.1 from 1.6, and at discharge was 1.8. And so we just the point here being that it can be done even with arteries that are compromised.
Did his blood pressure control get better?
I don't know.
Yeah. So one of the
That would
things
be something to.
one of the things I talk to the residents a lot, and I think it's relevant to both partial and radical nephrectomy is really pay very close attention to the CT scan, right? So we know that in atherosclerotic vascular disease, you're going to have calcification in the first 2 centimeters of the origin of the artery. And if you happen to put a stapler across that or a clamp across that, you may hold on to your britches because you may not be able to get good vascular control. So we always teach them because to dissect distally on the artery in both of those settings to where you have a nice healthy artery to do your operation. So I think CT is really
You can certainly crack the plaque and kill the kidney.
Yep.
If you take part.
Yeah.
Okay, who's next? Okay, Hassan, 59-year-old pediatrician. This case was given to me by somebody. 59-year-old pediatrician in 2007 had a 4-centimeter tumor in the left mid-polar region. He has insulin-dependent diabetes, hyperlipidemia, hypertension, moderate obesity, some stone disease going on, no surgeries. Creatinine is pretty good. So the CT had a left mid-pole solid enhancing mass, intrarenal, in a 59-year-old person who has diabetes, hypertension, all that good stuff. So here is the tumor in the left kidney, 4 centimeters, good kidney function, and you see all the diabetes, etc. So what do you want to do?
Again, this is a patient who has
Enhancing mass.
enhancing mass. This is an RCC until proved otherwise.
Yeah.
He has a history of nephrolithiasis or urinary stones. So that's actually a good indication to see if we can do a partial. Now, doing a partial and this one is not easy because it's completely endophytic. So personally, I will do it open, attempted with an intraoperative ultrasound. However, if there is somebody who can do it minimally invasive, I'll refer them to him. But in my hands, this is an indication to do or to attempt. I always tell them I will attempt, providing that the kidney is okay, there are no stones, doing an open partial with intraoperative ultrasound.
Okay, that's fair. And it was in 2007. And every indication for partial here, obviously, there's all this diabetes, hypertension, and all that stuff, and nephrolithiasis. So this patient at that time underwent a radical nephrectomy at an outside place in 2007. So good recovery and all that stuff. Grade 3, negative margins, excellent prognosis from that perspective. So at that point, but then he had 2 issues. One, his creatinine went up, his GFR went down to 47. We could have kind of predicted it, given his hypertension, diabetes, insulin-dependent diabetes at that. So it was the wrong decision anyways. But and then under surveillance, within a year, which sounds bizarre to me, but anyways, 3.2 centimeter right renal mass, a solid enhancing in the solitary right kidney. Okay, so clearly the initial left radical nephrectomy was an error, and now he has this 3.2 centimeter mass in the contralateral solitary kidney.
Yeah, it is difficult again, but
Do the same.
human beings do mistakes. This is part of being human beings, and if this was missed before,
Yeah.
we just have to deal with what we have to deal with now. And to me, I will again try to do a biopsy on this one,
Yeah.
just to confirm it is an RCC, because here losing kidney means dialysis.
Yeah.
Otherwise, if I don't have the facility and it is a solid enhancing agent, I will do what I said, or trying to do the right one, which is attempt an open partial nephrectomy with ultrasound guidance intraoperative.
So would you consider any of this thermal ablation? I mean, it's right there. Any of this stuff, or you want to go straight to partial?
Well, there is a biopsy, and there is an experienced interventional radiologist. Yes, I think it is an option.
Certainly. Well, anyways, so this patient underwent right cryoablation. Okay, and this outside. All this is happening out there. I'm just a historian telling the story. Okay, so laparoscopic right cryoablation, great recovery from that apparently, but ran into two problems. Creatinine went up even further, and now from 2008 to 2009, in 1 year, it is now 5.1 centimeter right renal mass with a 2.3 centimeter intra-aortocaval lymph node now. Same mass. You know, listen, the 3 centimeter tumor cryoablation is not very easy. You have to have at least 2 cryoprobes, if not 3, to get the whole thing. And inadequate ablation is bad news because it can actually, there are animal data that inadequate cryoablation will actually increase the oncologic potential by apoptotic factors. At least one animal study. But anyways, so in all probability, I mean, listen, somebody who took out the whole kidney on the other side, I'm not having a very high confidence in this team. And so they probably did an incomplete cryo, and now we have this lymph node.
How was that coded that
Laparoscopic cryo, correct.
Metastatic workup showed anything?
So that 2.3 centimeter node, nothing else. So here's that little node, and now this is 5.1 centimeters. Now what?
Tough. Again, to me, I will counsel the patient to go for cure. Probably he needs a right radical nephrectomy and lymph node
Radical?
dissection. Yes,
Okay.
and lymph node dissection to give him the best chance of cure. However, he will go on dialysis, which also in itself has problems. Now, an attempted partial nephrectomy and lymph node dissection is there. However, you see, we might jeopardize a window of cure of this cancer. So this is the way I see it.
So I think you're right. So that lymph node obviously is in the primary landing zone, right? Primary aortic cable for the right side of the kidney. So however you approach it, I would do a complete ipsilateral lymphadenectomy as the first thing that I do. And I think that if I had pathologically proven metastatic disease, I'd be inclined to do this, try to do this partial, keep the kidney, because obviously the metastatic disease is going to drive prognosis and risk of distant disease. And I think if you add on top of that dialysis, and the other, the trifecta of hyperlipidemia, et cetera, this patient's going to be in big trouble. Probably in big trouble anyway.
You're right. Okay, so the team at that point decided to do what you suggested, which is an open partial nephrectomy with RP editing. So he was scheduled for that. Then he showed up at the airport and developed acute chest pain, admitted to the cardiac ICU, acute MI, intubated for 2 days, eventually cleared for surgery, but now it delayed it somewhat more, and the tumor is now 6 to 7 centimeters. Poor guy just can't break,
It's just one on.
Yeah.
My question to that is most of the literature, cases for partial nephrectomy after cryoablation or RFA, it's a very difficult surgery and the outcome usually is not as good. And so a lot of them, I think 30 to 40% end up having nephrectomy.
So you have to count, I think the part I forgot, and you're pointing out, is that you can kind of go in with a plan, right? But that plan has to include that you may end up losing your kidney in order to dialysis.
The chances of losing the kidney
But it's not a given that it can't be done. So we've done many post.
Absolutely.
Anyways, the saga continues. So he had the surgery, as you said, Mohammed. It was challenging, but went well, apparently. Lymph node was that node was negative. And the cold ischemia time was 33 minutes. 30% of the kidney was removed. So went well, it said, up to for the first 7 days. On day 8, our friend developed bleeding. It was re-explored, open surgically. No definite bleeder, but capsular defect was open, reconstructed, packed, etc., etc. And so subsequently recovered okay. Creatinine was 1.7. It was a 7 centimeter grade 3 with negative margins. Okay, cardiac condition remained stable, but probably because of the cryo injury and all that stuff, then he developed a urine leak. And stent and drain placed and managed locally. So bottom line, the guy literally had every single possible complication.
What was the lymph node?
Lymph node is negative.
You know, Andy, this would be a fantastic oral board case.
Yeah.
It's the guy that reads that right, right?
I'll be happy to give it to you. You can put it in there.
You just missed one twist, which was so that after that he had the cardiac issue with the MI. He couldn't have any surgery for 6 months at least because he's on aspirin and diabetes,
Yeah.
and he was given TKI to keep it smaller for
That's
gas
right.
banking. Yeah.
So again, I mean, this gentleman should have had a partial on the left side to begin with, and then on the second side, potentially also a partial. Okay, Mohammed, 61-year-old healthy male. Okay, CT scan showed bilateral enhancing renal tumors, 5.5 centimeter mid-pole central on the right side, 6 centimeter hilar central on the left side. So 5.5 mid-pole central, 6 centimeter hilar central left side. Creatinine is good, kidney function is good, creatinine clearance is good, MAC3 scans, both kidneys are 50-50. So here you are, here's this tumor, and here's this one. Let me just take you through it. Okay, you can see some heterogeneity here, etc., etc.
I think
61-year-old healthy guy.
again, bilateral renal tumors, I would go for, I mean, it depends who's doing it. If it's you, I think it doesn't matter. But if it's me, I would probably go with the right side because if I do it and I'm happy with it, then I will go attempting the left side courageously. And
Look at the left side, that's just bad news right there.
Yeah, so I will do the partial on the right side.
Yeah.
I think it's doable robotically,
Yeah.
I believe, and then it depends on the outcome. But if I would also attempt the left side, but to me it would be a very difficult case.
So it will be staged, of course. So open lab robotic, you already went through. Staged is good. Right side first. So indeed, that's exactly what we did. This was many years ago, easily 7 years ago now. So we did a right-sided laparoscopic partial nephrectomy. Ischemia time was 20 minutes, and it turned out to be PT3A grade 3 clear cell RCC. Okay, and at this point, his creatinine, I'll show you the creatinine story in a second, but the creatinine settled down very nicely, and then he had this particular tumor. And so we told him exactly what he said, that you're likely going to lose this kidney, but we were able to get it laparoscopically. So ischemia time was 18 minutes, and on the left side, it turned out to be an oncocytoma. Yeah. Also with, it's not a centric steric scar, it's necrosis, as you said.
Yeah, can I just say one thing, Dr.
Yeah.
Bill? It is interesting that none of us mentioned the biopsy, maybe because we are from the school that takes the radiological diagnosis there. However, those folks who are pushing for the biopsy, if one of them was here, he would shoot us on the head. He said, why don't you do a biopsy first?
Agreed.
So we're to draw the line, you see.
I don't really care what the biopsy shows. It's a 6 centimeter tumor. He's 60 years old. He's at 30 years to go. We're not going to be observing this. I don't care what the biopsy shows.
Oh, but maybe, if it came back sarcoma, I suspect that most of us would really make a good faith effort to do it partially,
Right.
right?
Yeah.
Someone who may not have that level of experience, may look at that and go, okay, right kidney's in good shape, I'm gonna do a radical nephrectomy on the left, but if I knew it was an oncocytoma, with some degree of uncertainty,
Yeah.
that might drive me, would it,
To take a little more risk and do a partial.
right?
I'm just not sure in a 6 centimeter mass, one needle biopsy is going to be able to predictably the entire landscape.
No, but on the other hand, if it comes back, nuclear grade 3-4 renal cell carcinoma,
Yeah.
or some variant,
Yeah.
boom, you're done. I mean, and you're almost sort of looking for something that may drive you in one direction or another. But,
Yeah.
like we were talking about before, it is interesting, when you scanned bottom to top, I was thinking, oh wow, that looks like a really exophytic tumor. And so the interface with the tricky part is maybe a modest sized interface closer to the hilum, but the bulk of it looked exophytic.
On the right side.
So,
The left one,
just scroll through it again.
the left one was effacing. I don't want to go through it again now. But yeah, it was pretty intense
Good job.
and that's the story. And this guy was going deer hunting and fell out of a deer stand is how they got the CT and found this in the first place. So here's his creatinine after bilateral lab partial 1.3 and 60-40 function post-op. Okay, last case. So that 40-year-old gentleman, bilateral multiple tumors. Mother had bilateral nephrectomies for cancer. Creatinine is normal. GFR is 85, 48. What I haven't put on here on this slide is he's a multi-billionaire. You can handle these guys.
Well, I would tell them about my research program first. And then we'll get around to
We're
treating.
still working on this guy. Okay, so CT abdomen, multiple enhancing bilateral tumors, 15 on the left, 6 on the right, and then there was an intra-aortocaval 3 centimeter node, plus a left adrenal, 8 millimeter adenoma. And kidney function was left side 63%, right side 37%. Right is the one that had 6 tumors, left is the one that had 15 tumors on the CT. No VHL, we did the genetic workup, no VHL. So here it is. I won't obviously be able to show you all the tumors here. With the mother? No, other than the fact that she had kidney cancer. And so here we are. So what would you like to do? These are the only 2 CT scans I have, and obviously you'd want to see the CT in more detail, etc., etc. Our bottom line: 15 on the left, 6 on the right, and 37% function on the right kidney.
So the anatomic location of the lymph nodes would suggest that if it's metastatic disease, it'd be coming from the right. It may or may not, there's false positives, obviously, that you have to think about. When I send these patients to our minimally invasive surgeons, they send them back to me to do open. I think, but I'm fully aware that lots of people have experience doing these multiple tumorectomies lab. So again, whatever you're comfortable with.
Yeah.
I think here the question is, what side do I approach first? You could, under normal circumstances without the lymph node, I would approach the one with 15 tumors first. But I think with that lymph node, I want to adjudicate that. And so I might be inclined to start on the right.
Yeah.
And I think the goal in this setting, even without von Hippel-Lindau disease, you still kind of have to think about some sort of, and it's multiple bilateral. Obviously, you want to do nephron sparing, and so here's what you did.
Yeah, so that's what we did. Laparoscopic right side. 13 minutes was the total ischemia time. Overtime about 4.5 hours, 7 days. This guy developed significant ileus, and all 6 were grade 2 chromophobe and clear cell RCCs. Size range from 0.7 to 3.5. Margins were negative. That lymph node was negative, and then we brought him back to do the opposite side 3 months later. Total ischemia time for the 15 tumors was 35 minutes. We unclamped once in the midst of this. Blood loss was about 900 cc's. Stayed 5 days for some fever. Again, chromophobe and clear cell RCCs, 0.2 to 7 centimeters. So all margins negative. One was focally abutting the capsule at the margin at one spot. So this is the bilateral stage partials. So here is his story from 110 through 911. His creatinine is 2, GFR went down to about 50, and a MAG3 scan after all the stuff that was taken out, etc. 50-50 is the function. It's 1 year later. Now he is 7 years post-op. He developed 2 more tumors in the left kidney. So we went in and did a partial one time. That's tumor number 22, and then 2 years later we did a percutaneous cryo of the 2 centimeter tumor that came up on the left side. So now we are 7 years later. His creatinine at this point is about 1.7, 1.8, and now he has developed another 2 centimeter tumor in the right kidney now, which is anterior, close to the liver. And I don't think cryo is a good idea. This thing is going to just burn a hole in the bowel, etc. So we're getting ready to do it. And so now we are literally 8 years out, no metastatic disease, good kidney function. He's up to 11 billion now. All I've gotten is 200,000 from him yet, which sucks. But we're working on it. But so far, he is holding. It's a combination of enucleations, partial nephrectomies, cryo, etc., to try and keep this under good control, never letting any tumor now, since we saw him, get to the 3 centimeter range.
Very good.
And so that's where we were at 6 years. His
It's only about 10,000 for each tumor. I think
yeah,
we-
that's nothing. This guy can do far more. All right, I think the time is
Yes, that's good.
4:45.
Yeah. That's it.
Yeah, that's it. We're done.
So a great first day.
Can we show a case?
Sure, absolutely.
Because Zahani wants to show a case. But before you leave, all of you, please, the dinner tonight is 6:30. You are all welcome. In Qari Nexia, not the old one in Abu Bakr, the one in King Abdulaziz, just before King Salman Street. So it's, if you take King Abdulaziz all the way to King Salman, about 50 meters or 100 meters before King Salman on the right side. It's a very nice place, and it will be traditional dinner, and Allah يحييكم جميعا يعني الجميع. Bus from the Intercont will leave at 6 o'clock, and whoever wants to take his car or ride with one of the bus is welcome.
So Andy let you go today with like very nice easy cases. Like I walk at the park. Tomorrow, it wouldn't be easy at all.
Well, localized kidney cancer is so easy to take care of. I think it's India that makes it look easy.
So until the system opens, this is a patient that we have now on the floor. I think he's 60. Oh yeah, he's now he's so 80 years or so. He remains single in good health. Yes. And Dr. Ataybi did the radical cystectomy in him in January 2016, and the pathology was adenocarcinoma. He did very well thereafter, and we have a CT scan in November 2016, which was about 9 months after his surgery. So at that time, the CT scan has been reported normal. According to Dr. Schlick, there was a small lesion in the right kidney that has been missed. So as happened with Dr. Hill's case, sometimes things happen. So this is now the 2017. Now, he was admitted to another hospital with urinary infection, and the imaging was done there. So they called Dr. Ataybi that he has a right renal mass, and he was transferred to our hospital. So let's, Mohammed, if we show the CT scan of 2016, and show the go over. So November 2000.
So what was the operation that he had that showed adeno?
He had a radical cystectomy for adenocarcinoma of the bladder.
Really?
Yes. Adenocarcinoma of the bladder. You can show it the board. So we will not be showing the slide. So this is the 2016. Go up, Mohammed. Yes. So I think if you see here, this is where the mouse is. This is from 2016. I can probably show some of the other images. Yes, and it was now even. I mean, it is just when you go in retrospect. You can see here. So 2016. That's right. You will just follow it probably in 6 months. I mean, if anything, you will say let's follow it. And there was no hydronephrosis. Okay, because now the new CT scan is showing more actually challenging issues. So this is now the recent CT scan, and I will show you the one with contrast. So what we see now, and what has been reported by our radiologists, is this mass, which you can see now. But look. It is starting on the renal cortex, it is going to the collecting system, and oops, it may be actually touching the renal vein. So this is on the right side. There is no hydro on this side. There is no history of hematuria. But also on the left side, there was no hydronephrosis a year ago. And now he has hydronephrosis. So you can follow this left ureter and keep following it and keep following it and keep following it and keep following it, and soaks. Even now, the left ureter, you can see here, as it crosses to meet the ileal conduit, it is really thickened. So this is the case that we have now. So maybe Dr. Lerner, what is your suggestion? How should we manage this patient? Yes, he's in good health. So yeah, yes. So yes, single. Yes, this is unusual for Saudi. But if they live to that age, it means they have enjoyed their life to the maximum, and they want to keep enjoying. So that's why we need to treat him. Yeah, our radiologist report this one as upper tract TCC on the right side, which I personally have my reservation on that.
What's his creatinine?
Yeah, I can show it all. Yes, he's fat, but I can show it to you in the real because you see, luckily now, we have information technology. Let's open it. So you believe us now? He's 79. That's his age. And now this is his CDC.
Show me the single status. I don't see the status.
So this is his CDC. His hemoglobin is 113, and his creatinine is 95, which is normal. Yes, actually it was like 1. Normal kidney function, no evidence of metastasis. The chest is normal. Metastatic workup is negative. Yeah, CT chest is negative and alkaline phosphatase is normal. Not the cystectomy, the nose were negative, and the pathology I'll show it to you now. Yes, I can show you the pathology.
Do you have confidence in it being a pure adeno as opposed to a urothelial with adeno?
That's a good question, sir.
I have confidence in it.
Actually, yeah.
But I think that generally the way I like to approach when I've got two things maybe linked, right? But I got two different problems. I need to adjudicate both of them, and so it looked like what does he have, a conduit?
He has a conduit, sir. Yes.
Yeah. So I'd really try to visualize what's going on in the distal ureter on the left, and I'd run a scope up there on the right if I, given the ability. And see if these two things are somehow related.
Yeah, so this is his bladder, adenocarcinoma of the bladder, poorly differentiated. Tumor size is 1.6 centimeter in this dimension, tumor located, so it's adenocarcinoma. Sorry, I missed that.
What was the pathologic tumor stage?
Pathological tumor stage, let me, it is PT1A.
That's prostate.
Yeah.
So he's got an organ-confined cancer with negative nodes.
Yeah, it is T2. Yeah.
But he's got lymphovascular invasion, so that's a risk factor for recurrence.
Let me go back to his X-rays, just to have everybody refreshed. So yes, Dr. Luna, you said you will try doing.
So I've got to deal with the left kidney because if this is urothelial,
Yes.
I'm going to want to get chemotherapy.
Yes.
Okay. All right. So I've dealt with that, and you may just. It could be a ureteroileal anastomotic stricture. But you got to prove that there's nothing going on in that distal ureter from a malignancy standpoint. So you optimize. You get the kidney drained, which you've done.
Yeah.
And then I think you need to get histologic confirmation of what's going on the right side because it's going to drive decision making. However you have to do it. But I think that, I'd first try to run a scope up there.
Yeah, through the ileal conduit?
Yeah.
Yeah, actually I have no experience with it. Anybody has done ureteroscopy through the ileal conduit? Yeah, sure. So that's something that we can try. We can attempt it.
Now,
So what about if we fail to get the scope up in his right kidney to see what is going on in this one? What about taking a biopsy?
Well, you could biopsy that pretty. The radiologist could biopsy that pretty easily. Yeah. Obviously get a cytology if you can. Get a. Yeah. So yeah.
So.
Yeah. You can get, obviously you can get urothelial cancer going into the renal vein. Renal cell carcinoma would be much more likely, but I think that, in a setting where you're not quite, I was going to say where you're not quite sure where the epicenter is, but the previous one would suggest that it was parenchymal, right?
Yes, that's the 2016.
Right, so, I'd still biopsy it.
Yes. Sure. Sure. Yes. Yeah. That is a possibility because this is a very thickened ureter causing hydronephrosis.
Well. Looks pretty apparent, I think.
Yeah, actually, the report we got, Dr. Gill, this is a urothelial, but I personally, again, might have a reservation, and yes.
So if you think about, sorry to interrupt you, if you think about the timing of the issue with the left ureter, right?
Yes.
And you've got a pure adeno,
Yes.
I would think it's less likely that hydronephrosis is it could certainly be malignant, but the timing is very consistent with ischemia. You know, these strictures are ischemic, right? But now that you've got, but I still think the point is important to, you know, because you've got both sides involved, maybe with different processes, is to nail down what's going on both sides. But that's kind of what I'm thinking. When the date of how long ago was the cystectomy?
Sure. So the cystectomy was January 2016. The images we have, the first one in 2016 was in November. So that was about 9 months ago.
Hydro. Yeah,
Right.
but the
And the left ureter at that time was fine. What
That
they
was
missed
in-
is the small right upper ball lesion. So ischemia usually, I mean, we have seen a few cases. Usually they are a short segment, not that long segment.
oh, but remember that part of what's going on the left side may have to do with you brought it underneath
Swinging
sigmoid
the-
mesentery,
Yeah.
and you normally get some dilation. Obviously not. This is pathologic hydronephrosis.
Yeah.
So. So
You see here, Dr. Lerner, I mean, this is the ureter, and
Yeah.
now when it starts taking off the turn, it's about
yeah, but
couple-
you see the real dilation. So you could have a long ischemic segment there. Okay, because that's starting from where it comes underneath the sigmoid mesentery and
Yeah.
coming over to the butt end of the loop. You can see that. I don't know what that clip is doing there,
Sure.
or if that's part of the process, but that could be a long ischemic segment as a possibility. But
So what we did so far is we inserted a nephrostomy tube, and we are trying to figure out what's going on with his left kidney first, to see is that a tumor or structure or whatever it is, and then we will take a biopsy, and then we'll decide what is the final pathology. But
So-
this is still an ongoing case, actually.
So that's a good point, Indy, because when I'm talking to the radiologist, obviously my goal is to decompress the kidney.
Yeah.
But let me go ahead and see if they can get something across
Yeah.
into the conduit that I can actually then use for access.
Sure.
And from just a patient comfort standpoint, you obviously can cap that and you're not having to walk around with a bag.
No, they just decompressed it now. Yeah. Yeah.
Yeah. Didn't go across, yeah. So I'm thinking you might have a long ischemic segment there.
Yeah, actually, that will be probably better than having a urothelial cancer there. It
Generally
just makes-
speaking,
yeah,
that's
generally
better.
speaking, yeah, that's better.
That's fixable.
At least if we do a nephrectomy on the right side,
Yeah.
then we can just refashion his diversion.
Yeah.
I think we'll just leave you.